how are they responding? Are they responding as a law enforcement agent where they're going to take somebody that has psychosis and paranoia and delusions? Are they going to take them to the hospital, or are they going to arrest them because they're having these delusional behaviors?
Hello, everyone. Welcome back to Between Generations, A Life in Two Voices. We are here cozying up with a very special guest today. We have Charli Prete. She is an LCSW and a mental health clinician for the South San Francisco Police Department. She has over 5 years in the mental health field, and she's very, very passionate about it. I have talked with her, I've seen her in action, and I just love everything that you do for the community and the way that you articulate and process how you're going to do things, how you're going to care for people. This is a very big job. And so to be able to take hold of that is very, very special. So welcome, Charli, to the show.
Thank you. I appreciate having me on. Well, I want to give you a little bit of background on who I am. I went back to school later in life, which was nice because I really started to enjoy myself and enjoy the classes more. Like Natalie says, I work for the South San Francisco Police Department. I am embedded. I'm with the Crisis, Wellness, and Community Response Team, otherwise known as the CWCRT. In that role, I respond alongside officers to mental health crisis in real time. Everything from suicide ideation, psychosis to youth violence, which is something that is I'm passionate about too. Um, Also, I um, encounter substance-induced psychotic emergencies and family disturbances rooted in like untreated mental illness. I also work as a part-time clinician for Journey of Life Counseling Center, providing telehealth services. Um, but I work with adolescents to youth there. In that setting, I focus more on trauma-informed care, mood disorders, and substance use, and supporting individuals navigating complex life and transitions. I've done this, as you said, for 5 years, but I think I've always done it my entire life. I just didn't know I was doing it. So that's the exciting part. That's what brought me to that's my favorite part. My deeply compassionate part of this is I love bridging the gap between law enforcement, community systems, and behavioral health care. My work sits at like the intersection of intermediate crisis response and long-term healing. So that's me in a nutshell. So yeah.
Very cool.
Wonderful. That is a lot. A lot. All of those different facets of being a mental health clinician really just lends itself to having a wide scope of knowledge. And that is something that also we're going to learn about today. Is just all of the ways that your mind works around all of these different types of behaviors, right? And presentations. So that's beautiful, Charli. And to only be in the field for 5 years, honestly, if I hadn't asked you that question, you give off the vibe that you've been doing this for a very long time. So that's very special.
Yes.
Honestly, like I feel when I met you very calm in your presence. So that's really beautiful.
Charli, thank you for taking the time to join our podcast today. The mental health field has always fascinated me. I've found that work not only helps you understand others, but also teaches you so much about yourself and how to show up with more empathy and awareness. So, what originally drew you into the mental health field, and how has that motivation evolved as you've worked with different communities?
That's a really good question because I think it really drew me in by my lived experience. I grew up in a home where mental health wasn't talked about in healthy ways. My mom had mood disorder and other mental health issues. She attempted suicide several times that I know of when I was growing up. My daughter has bipolar disorder, who lives with me now. And my brother-in-law had schizophrenia with paranoid and delusional behaviors, and he lived with us for almost 8 years. So I was really connected in the mental health field. But later in life and during the pandemic, I realized I've been doing this crisis work for a long time.
Yeah.
And I just didn't have the title yet. So I went back to school and got my MSW. Felt like this stepping into what I already was wired for. So that's kind of where I was at. Um, my motivations over time kind of changed from just helping people in pain to something more systemic. I, as you know, I'm embedded in the police department, and I'm
Yeah.
not now just supporting individuals. I'm working to change how the system responds to mental health crisis. That's kind of what drives me today. I mean, I
Yeah.
really like that bridge between law enforcement, families, and community care.
So, help me understand what does what is law enforcement's involvement? Can you kind of explain that?
Sure. Law enforcement and I go out together on mental health crises. They get called out every day. Before I was there, and now that I am there, they get called out all the time. How did they deal with it? That's the thing that we are looking at. What are they doing? How are they responding? Are they responding as a law enforcement agent where they're going to take somebody that has psychosis and paranoia and delusions? Are they going to take them to the hospital, or are they going to arrest them because they're having these delusional behaviors? We don't know. So my way we're bridging that gap is to allow the police department to become aware of how to handle this. What's the difference between substance use psychosis and what's the difference between just having psychosis? Can you put them on a hold for just psychosis? You know, there's a lot of different ways. And what I'm doing is bridging that gap and allowing them to understand how to deal with mental health instead of persecuting somebody and prosecuting somebody. They are starting to learn how to be more empathetic and help them through the crisis. So that's what I really am starting to enjoy to do.
Pretty fascinating. Because then, would the police department, what would they do typically? Would they take them to jail, or would they?
Um, it depends on sorry, don't mean to interrupt you.
No, 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 go
Um,
ahead, go ahead.
it depends on the police department. I really want to say that it depends across the nation. We have some police departments and some are very good about handling mental health crisis. And then we have those that don't understand it, think it's just them trying to get out of being prosecuted. So we're trying to develop a program that allows them to see what's really going on.
Yes,
I'm not saying that everybody that commits a crime has mental health issues. I'm not saying that. But I
sure.
am saying that they have to dig a little bit deeper sometimes and find some empathy and find some way of helping this individual other than taking them to jail.
Okay. And I have one more follow-up question. If you get a call, or does it come into the police department, and then the two of you would go out together on the call?
It depends.
Okay.
It usually comes into the police department. Usually, that's basically goes through dispatch. Somebody called 911. Something's going on. Who knows? I get dispatched out with the police officer. They first make sure that the scene is safe for me. That's the very first thing. I always call them there, and then I can go and proceed. If there's any kind of weapons or anything like that, they make sure that I'm protected first and make sure that they're protected as well. But before I can even get close to the individual. Um, but I do go out with them. I get dispatched. We're called the Henrys through the county, which I think is really funny because my call sign is Henry 3, and everybody has a Henry call sign. So we get called out and we dispatch out. We go in our own cars. We don't actually go in with the PD. Um, Sometimes I have to wait and stage until they tell me it's good. Other times they're telling me to get in there and help this person because they don't know what to do.
Yeah.
Um, but it kind of depends on, where we're at. I do get referrals from the officers, which saying this person just needs some help. Can you help them? Can you call them? Can you go out and see them? And those times, sometimes I'll take an officer with me, depending if I'm feeling safe or not safe. Other times I will just go out. Sometimes I just do it by phone. But there's a lot of different ways that we help each other out.
So of course, I've got another follow-up question, but this is all good. Is Since I'm familiar with California, Northern California, I was born and raised there. So, if I remember correctly, South San Francisco is part of San Mateo County, or is it its own
That's
county?
correct.
It is correct. Okay.
That's correct.
So is each town doing this? For example, San Carlos, Mountain View, or is it just exclusive to certain cities?
I think it's exclusive to certain cities. Luckily, in San Mateo County, I think we have 9 or 10. I can't remember how many clinicians we have now. It keeps building, so I don't know, which is great. But they are right now. They're being either hired by in person hired by the city, or either Felton Institute or San Mateo County. I originally started with Star Vista, and then we were contracted into the police department. But
Okay.
now that there's no longer Star Vista, I'm now a hired employee at the city of South San Francisco, which just happened recently, which was great. As
Yeah.
far as Northern, and I know Oakland has mental health clinicians. From there, I don't know who does or who doesn't. It's sporadic. Not every PD has it. They should, but they don't. Um, it depends a lot on funding too, though. We're not cheap.
Yeah.
So we have a lot of things that we need to do to grow this program.
Yeah.
I think we did the pilot programs for now. Well, pilot program was like 5 years ago. And we got through that pilot program, and it is showing the decrease of hospital admissions for 5150s, which is a good thing.
That's
Um,
fabulous. Yeah.
yeah. So more people are getting connected to housing, to substance use programs, things of like that. And that's what we want to do.
And you have access to that data, so you can see, um, what the progress of the program.
Yes. My
Okay.
my captain shares it with me quite often.
So it's successful. You can see that, a certain percentage of people have moved on and they've gotten settled, and that's a good thing.
I've had several success stories, and then I have several that aren't. But it's kind of finding that balance.
Yeah. Yeah. Sure. Natalie, do you have anything to add before I go into question number 2?
I was just going to say, I'm sure viewers are seeing my facial expressions. And the reason being is because I am the clinician at the Belmont PD. And so Charli and I do something very similar. So, Charli, congratulations that you just got brought on to the PD. They have a true gift under,
Yes.
their roof. So this is it's a great thing for the community. I love how you describe the different facets of being a clinician co-response with police officers. It's a very different dynamic. I'm still getting used to it. And I'm sure it's taken you some time to like even just build the relationships, right? I guess my follow-up for all of what's being shared so far is what does that look like for you? Building the relationships with your captain and the police officers, the people that you work with at the PD.
It didn't happen overnight, that's for sure. Um, with my captain, he was all for it. I'm very lucky that I had a captain and a chief that really wanted a mental health professional in there. I got lucky. I got really lucky. Um, but when I first got there, I noticed that some of my officers was a little skeptical about why I was there and
Yeah.
if I was going to stay. That was the other thing. Do I get attached to her? Because crisis work is hard. So some people
Sure.
can't handle it. But kept reassuring them. I kept being with them. I went to all the briefings and just kind of made myself known. I'm here for you also. I'm just not here for I did trainings with them. So I just wanted my face to be there and for them to understand. I made sure we have a golf tournament and like a fundraiser. I went to it. I don't play golf. I had a blast though. It was fun. I made sure I went to all the county, or not the county, I'm so sorry, the city hall meetings. Thing that connected me to the
Sure.
PD, National Nights Out. I volunteered for all that stuff. Um, I think the change though was when I'm so sorry, but we had an officer involved shooting and I was
Yeah.
there for the officers. And
Wow.
that really helped. Um, kind of That's when they started to see that who I was. I'm also part of their peer support team now. I'm part of their crisis negotiation team. I'm also doing some other training with them. Um, it the more you kind of get into their type of mentality, then they understand. Doesn't mean you have to believe everything they do, but it just means that you understand where they're coming from. A lot of these officers are just humans that are out there trying to protect their community. And
Sure.
I'm so lucky with South San Francisco because community comes first and
Yeah.
then safety comes. And it's just a great program.
And I would think too that from an officer's perspective, you're coming into their territory and maybe what do you know? What are you going to add? So, and they see brutality. They see nasty. So they can be rough around the edges as a cop. So these networking programs, provide you the opportunity for you to get to know them on a personal level and vice versa, like you said, which is good because then, the two, it's like a marriage, right? You're both out there trying to help the community. So that's a win-win. That's awesome. That's awesome. So Charlie, when you think about the clients or moments that shaped you the most, what stands out about how those experiences changed your approach to care?
Such a great question because I have shifted so much probably since I started. But one of my first calls, I remember this. It was my actually first call, and it was with one of my colleagues. We went on a death by suicide, a
Oof.
completed suicide. Um, sorry. I was sitting there with the mother who just lost her daughter. There's nothing in graduate school that can prepare you for that, by the way.
Yeah.
Um, I remember realizing in that moment that my role wasn't to say like anything profound or to fix anything. It was just, I was just there to hold space for her. Um, to tolerate that unbearable with somebody is life changing. It really is. It's life changing. Um, so sorry. This one gets me every time. I'm sorry. Um,
This is fine.
that experience taught me that my presence isn't often more powerful than my words. I didn't need to fix it. I just had to be there for her. And that one, I learned how to give space because I always wanted to fix everybody. And I couldn't. I just had to be there. The irony of that is I moved around the corner for a year around that home. I didn't realize when I rented the apartment, but it reminded me every day just to hold space. Um, there's a lot of other ways that it's changed me. It really has. I see life differently now. I see myself as a mental health clinician different. Um, working with youth, I realized that these youth come in because they feel trapped or they feel like they're suicidal or need violence because there's bullying going on or they're suffering from depression or identity struggles. Who knows
Yeah.
what they're going for? I learned how to understand how hopelessness can escalate when they're not feeling unseen or they're not feeling unheard or they're feeling unheard or unseen. So I take a different approach now with youth. I used to want to just get to the point. That's what I was supposed to do
Yeah.
is get to the point. I no longer do that. I stop, I breathe, I slow down, and I stop jumping straight to the so sorry. The mid the risk assessment and begin to just listen. Just hear them out. Ask them what's going on. Sometimes that's all they need. I also work with people with psychosis. Some are substance-induced psychosis, of course, and some are um, chronic. But I always thought I needed to fix the I'm so sorry, I went blank on my words. I apologize.
No problem.
Sometimes I want to fix the symptoms. I want to stabilize the symptoms of the psychosis. That's what I thought I had to do at first. Now I just stop and think of who they are as a person. Give them some dignity, because even if you have psychosis, you still have or should be having dignity in this part. Doesn't mean you play into their delusions, but it's okay to acknowledge that that's what they're seeing or that's what they're
Yeah.
hearing. Might not be what I'm hearing and seeing, but it's what they're doing. And that's how their brain works. I can go off on a tangent on that, but I'll stay focused. So I really start validating the situation without um, validating the delusion, of course.
Yeah.
So, but my biggest thing that has shifted, I think, in my career, is the systemic issues. I thought once I put them on a hold, they were going to fix everything. That's what I thought when I first got to crisis. But then I realized how certain systems kind of marginalize individuals. They call them difficult or non-compliant or frequent flyers is the one that I hear all the time. Those words are starting or have started making me uncomfortable. It's like, no, these people are human. That's all they are. Human
Yeah.
with dysregulated nervous systems. That's what it is. And so I really want to bridge that gap. That's my kind of drawn to this systems, the systemic issues. Oh, I could go on for days about that.
Sure.
So I'm trying. I'm trying to think. I'm sorry. But I think this work has also softened me a little bit. My wife can contest to that. Um, I believe that I've started to kind of be more of generational trauma. Um, I protect dignity a little bit more. And I'm really committed to changing the system and making somewhat of a progress. Anything, even 1%, just something to show that we're helping these individuals.
Natalie, do you have something to add before I ask my follow-up comment, or I have a follow-up comment?
No, well, just thank you, Charlie. I mean, you really articulated that question so beautifully. I think you hit it spot on. The way that we think about mental health and being a clinician has absolutely changed. I didn't know what I was walking into. And now that I'm doing it, and as you verbalize it, I'm like, yeah, that's all the things that I do. And then I get down to just looking at this person and just be just heartbroken because this person is really hurting. And I don't want to fix it, but I want to help. It's such a weird place to be in, but I totally understand and feel those words, and I love that you bring your essence to it, right? Like you bring yourself. It's really not the hat of
Yeah.
I'm the mental health clinician and I'm the expert. It's no, I'm the other human being that is here on this side, and and maybe I can help you get to this side slowly. But I
Yeah.
hear you when you talk about the systemic barriers and just the prejudices and the stigmatizations of just this world that we live in. It's hard. There are some fantastic programs out there. You and I both work with them. But the reality is that it's intricate, and we can't just think that we can pass off people from organization and program and think that it's going to be all solved. So, you are, just, you know, moving through this space with, care. I love that. So I'm, happy to be in this space of just learning from you, because that's exactly what's happening, and I love the networking part of it. You're doing some really good work.
Thank you.
Charlie, do you think did you already have a fair amount of empathy going into this?
I believe I did,
Mhm.
and I hesitated on that. I thought I did. Let's put it that way. And I was like, I've been through experiences. I've been unhoused. I've been, through the CPS process. I've been in all those situations. And I thought, oh, I will bring those and bring empathy to the situations. But I think as I'm growing as a clinician, and I'm still growing, and I will continue to grow until I'm no longer um, in this. I really believe that empathy is something you don't learn. It's something that you either have or not have. And it's something that you can develop, but you have to learn how to feel and be okay to feel, but yet still take care of yourself. Because if
Sure.
you're so empathetic, then you're not protecting yourself too. So there's a balance. Once again, there's that balance that we have to find.
Sure.
Um, but I've seen it. I've been there with mental health. My daughter, my brother-in-law, my mom, and some other that I've worked with. Um, but as I've grown as a clinician, I think I'm becoming more empathetic. I'm going to say empathetic with boundaries. I think that's a really good way
Yeah.
of putting it. Um, you have to see the human in these people, because a lot I deal with is I deal with the unhoused probably the most. That's probably my main I go out with. And they're also doing substance use because there's a whole systemic issue in that. At first, I didn't understand the drive of substance use in the unhoused. I didn't. That's honest. And I have developed like this empathy and understanding on why they are using, or the reason why they're unhoused. They're humans. Life happens. Life just happens sometimes. And I'm really starting
Yeah.
to feel that.
Yeah. Mental health work requires so much emotional presence. How do you stay grounded and protect your well-being while supporting others?
Patience, no. Humor, that's a big one for me.
Yeah.
But basically, I try to stay calm. You are walking in with crisis, you're walking into chaos, and you don't know what kind of chaos you're going to walk into. You have no idea. So
Right.
I have to find myself to be the calm person, the one that comes in, okay, we got this. It's okay. And not being anxious. I have to tell you, I've been anxious on a scene, and I can tell you it didn't go as well as it should have. So, you have to learn how to do that. You have to take that moment right before you go in, take that breath work, do what you need to do, whatever works for you so that you are ready. I don't let the officers love to stand outside my window and tell me what's going on because that's what they're trained to do. I make them wait until I'm ready to get out of the car. That's
Yeah.
something I need. And they're starting to understand that. My younger officers aren't quite there yet, but they're working on it. So it's good. Um, where do I want to go with this? Sorry.
No,
um,
you
like, um, there's a couple things I can do for myself too. Is um, like I said, I consciously slow my breathing. I lower my voice. I also meet the client where they're at, but a degree lower. So if they're really escalated, I bring it down. Um, but I want them to know that I'm okay with that. That's okay to react. It's okay to have those feelings. It's okay to be upset. It's okay to cry. It's okay not to feel. It's okay not to be okay.
yeah,
You know, that's the very first thing I do on a scene. And that's to protect me more than it is anything else, too. Um, After a scene, a call, I sit in my car for 60 seconds or more, sometimes more, and I do some breathing. I love to do my breathing in the car, really ground myself. You never know, I might be called out again in that moment, which it does
sure.
happen. I go back to back calls. Um, I do leave work and I leave work. I don't take it home with me, or I try not to.
Mm.
I'll try not to. Sometimes I do because it's the last call and I haven't quite brought down, you know. But I have a 2-hour commute. I sit on BART and try not to bring anything home. Um, I don't carry heavy cases by myself. Try to make sure I get consultation or I get to what I call venting to the other clinicians that are around, or even the officers, so that there's this kind of debriefing, so that you're not carrying that heavy load anymore. Um, my grandkids are my reset button, is what I call. When I get home, they're here. They don't care about what calls I have been on. They don't care about uh, 5150s. All they care about is me be present for them. And so that's my reset button. Um, and I like going to the water and kayaking, but I haven't been in a while, so I can't say, you know, I have to do that again. I meditate every night before bed. That is my thing. I now can't sleep unless I meditate, which is crazy. I never realized how important it was. So find a good meditation and stay with it.
Yeah.
And that allows me to clear my head and I don't bring them within my dreams. And that's really important to me. Um, I also have, I'm, I, I guess I'll disclose this. I have multiple sclerosis. I have MS. And that's taught me that if I'm pushing myself too hard, my body shuts down. It says, no more.
Yeah.
And so now I've learned to listen to my body. So I know when to go and when not to go. If I don't feel up to it, guess what? I'm going to take a moment and that's okay.
Yeah.
So, so MS has really helped me through that navigating my life. Um, and I've been dealing with that for 25 years. So,
Wow.
like I said earlier, I love humor. I love to laugh with the officers. We were at a scene. I probably shouldn't share this, but it was funny. And this gentleman ran into an English classroom, had to evacuate the whole school, blah, blah, blah. And the funny part of it is he wanted to smoke before he came out. Nobody had a lighter, or they wouldn't give him a lighter because of such cause. So he's trying to find a way to spark to get
Dear.
to light. I looked at the PD, really serious, and one of my officers, I said, why didn't he go into the science lab?
Yeah.
Why English? He could find something in the science lab. And so
Yeah.
we have to
Yeah.
find humor. That was on the scene, and they caught it on their cams, and I was cracking up because now they tease me about that.
Yeah.
But you have to find humor, and everybody kind of slowed
Yes.
down when that happened, and we got him out within a half hour. So it was just cute.
Yeah.
So find humor. Humor is the best thing, I think. But I also normalize things. It's just who I am. We all go through crisis sometime in our life. And everybody says they don't. Your crisis might be smaller than somebody else's crisis, but everybody goes through a crisis some point in their life. And we have to remember that we are meeting these people at their worst time. So I just kind of humanize them. And that helps me understand where they're coming from. That's about it.
Interesting. Very, very interesting. Because you had mentioned too earlier that you have your daughter and your brother-in-law, and so you go from crisis to crisis. Like how do you balance going home and dealing with that after coming off of work and dealing with humans that you don't know?
Well, my daughter lives with me, and rest in peace, my brother-in-law passed away a few years ago. So he's no longer with me.
Yeah.
But we all lived together at one point. I think what helps me is my grandkids. I'm like, they're my
Yeah.
life. My daughter is very emotional at times, but I give her space too, just like everybody else. If she needs to
Yeah.
vent, I listen. But I also say to her that if she's way up there and I can't deal with it, I'm like, I'm sorry. I love you, but I can't do it right now. I don't
Yeah.
have it in me. And she respects that boundary because she knows what I do. We're very close. Um, but like I said, I meditate. I go take long baths. I watch TV or play my games. I totally just kind of zone out
Yeah.
for my
For
purposes.
recharge.
Yeah.
Sure.
And then I have my office, and I go into my office. It's very meditative. Have all my things that I can go to and just be here. My chair is a massage chair. So if I want to turn it on, I can, so things like that. I really try to take care of myself because if
Yeah.
I can't take care of myself, then I can't take care of anybody else. And
Sure.
there's something I always think about. I can't not pour from an empty cup. You don't get anything out of it.
Yeah.
So if I were to sustain as a clinician in crisis, I want to take care of myself. I don't want to be a burned out clinician because that's who leaves the field. I want to keep doing this work. I love doing this work. I'm
Yes.
passionate, but anybody that commutes 2 hours on BART both ways has to be passionate somewhere.
Sure.
Somewhere. I love my job. I've got offers to be Antioch, work with Antioch PD. And I'm like, no, I like my South City. I love
Yeah.
those, you know. Um, so I treat myself good.
In your work, how do you see family dynamics shaping a person's mental health? And what patterns or strengths uh, stand out across generations?
Well, as you can see, I have quite a few in my family. So
Mm.
mental health wasn't talked about in my house. And if so, it was because my mom, quote, was crazy. That's what they said,
Yeah,
you know, or she was, going through menopause or something female related. That was
yeah,
what was portrayed at my home. I didn't want that anymore. But I think mental health doesn't develop in isolation. It kind of develops in relationships, you know. Um, I often see how patterns across generations, they're not because the families don't, it's because they pass down the tools that they were given at that moment. I don't know if that makes sense.
it absolutely does.
But one of the most important threads I see in generations is silence around mental health. We don't talk about it. Yeah. Um, you don't talk about depressions. You push through it. Your anxiety wasn't named. Trauma wasn't processed. And when pain isn't given a language, it becomes a behavior instead.
Yeah,
I think that's where substance use comes in, kind of the picture. Um, I think substance use is one of the strongest generational patterns that I see. But I don't think of it as a root problem. I see it as an inherited coping skill. I know there's some genetics part of that, vice versa. We all have that knowledge. But I really think it starts with like an inherited coping skill. You know, like some things that come to me, if a grandparent was surviving war, or poverty, abuse, racism, or a loss without any emotional support, alcohol or drugs were the only thing available to calm your nervous system. There wasn't language for PTSD or depression. There was just have a drink, calm down, you know, and don't talk about it. So I think really um, that became a really way of treating depression, taking drugs for psychosis. And I'm not talking um, medically drugs, I'm talking about street drugs. Um, how do you fix domestic conflict? Somebody goes out to the bar and drinks,
yeah,
or they drink at home. Suicide ideation. Let's get
yeah,
stoned so I don't have to think about it.
yeah,
And I think when I respond to people with psychosis with substance use, I have to really think about what's going on. What's behind it? What is that generational part of it? Where is the family? Where is it family systemic issues? Have they been kicked out of the house? Have they gone through a divorce? Have they can't be who they are because their parents don't accept it? You know, those are the things we have to look at. And those are the patterns that I see. I see psychosis, and some of the psychosis is substance induced. It is. And sometimes they've used substance so long that it's permanent even after they become clean.
yeah,
And we see that with the unhoused a lot. I mean, that's where it is. They lost a job, they lost their place to live, they lost their family, all that. And now they're using. Now they're using.
yeah,
Um, but I also see some good sides too. I want you to hear that. Those are the negative. I also see that um, families support family. They want to change. They have fierce loyalty to their kids. I see it a lot. I really want to
yeah,
help them. I see a lot of cultural resilience. Yes, my family doesn't believe in mental health, but I want to change that. Um,
wow,
trauma can also like travel in generational, you know,
Sure.
they, so that's another pattern that I do see a lot, that generational trauma, um, you know, can amplify trauma too. I always think substance can mask it, but the thing that we do out there in the crisis situations, we can also make our healing process travel too. We can take that step and help them understand what they need to understand. Not fixing it, just letting them know that it's okay to talk about psychosis. It's okay to be hurt. It's okay to be you. So sometimes it's not about fixing them, it's about giving them information and letting them know it's okay. That's one thing I do a lot is I validate. And that especially with generations. I look at parents or I look at the grandparents and just say, I see this a lot. It's okay. So we're breaking the cycle a little bit. But there is a lot of generational trauma.
In the sense that, do you think it's inherited? There are certain aspects of mental health that are passed down from generation
I
to
do.
generation? Yeah.
I do. I think there's some genetic part of it. I really do. But
Yeah.
I also think that it's the genetic component there. But I think not everybody that has the genetic component has mental health issues.
Yeah.
So if we're breaking the cycle of that and speaking out and talking about it and figuring it out ahead of time, we could do something about early recognition.
Yeah.
It's kind of like in autism. If we start teaching children with autism early how to respond, how to live on a daily, do their ADLs, how to, just have small eye contact, that kind of stuff. If we start doing that and integrating it early, then they can live a life on their own and not be in coach. That's not true for all kids with autism, of course, but early intervention is the key. Early speaking up about mental health is the key.
Yeah.
Teaching kids having social or emotional learning is the key. So for generations, yes, there is a genetic. And some people, even if we have early intervention, will still have psychosis, will still have schizophrenia. That's not where I'm going. But I really think
Right.
we can bring them into a process where they can learn to live with it. And that's where that goes.
You seem to be such a beautiful spirit, Charlie. I really value every single thing that you are saying, and I really appreciate it. So, with Natalie's blessing, I may contact you to become your friend. Figure out certain, it's good to talk to people that share some commonalities and just to talk, and it's
I agree. You can call me anytime.
I feel your spirit from here in Virginia, and I'm drawn to that. It's quite helpful for me, and it's calming. So I appreciate you. Looking ahead, what changes or innovations in mental health care give you the most hope for the next generation?
I debated with this question a lot when I got the question. I think there is hope. So I want to bring that in. And for a long time, mental health, law enforcement, courts, hospitals, housing services, or any of that were working parallel to each other. They weren't working together. Now that I'm embed it with the PD. And now that I see that we're starting to integrate more with those systems,
Sure.
I believe that shift's going to matter. I think my big thing was the SB 43s. In theory, it's a great program in theory. I really wish the best for this program because I think it's going to just soar if we get the right people. I don't know if you're familiar with SB 43. It's the California Senate bill. It expanded the criteria for gravely disabled. I'm going to read it because I can never remember
Oh,
it.
yes,
Um,
please.
it's to include severe substance use disorder alongside serious mental illness. So it coexists now. We can put them on gravely disabled if we're seeing a decline in their mental health, and there's substance use also. And that includes alcohol, anything, opiates, whatever.
Yeah.
That's a really good concept. And what they're supposed to be doing is once they get placed on a hold for this, they go into the psych emergency. They have to hold them for the 72 hours. And then they have to do a new assessment on their mental health. Because what's been happening prior to this was they would get in, they would get sober, and the hospital would release them, never addressing their mental health. And as I said before, substance use and mental health usually go side by side. Not always, but I'm going to say pretty much the majority of time. I would go at least 90%. Because you're either hiding something, you want to not coping well, or you're living out on the streets with mental health.
Yeah.
So it's a good way to intervene. That's what they're supposed to be doing. That's what they should have been doing anyways. This is where I get passionate. I'm sorry. My
Yeah.
calmness might not be there anymore. And for the last 2 years that I've been at the PD, I have seen patients or clients go into the hospital, the psych hospital, under the influence, they split their throat or cut their arms, saying they want to die. They sober up and they know what to say, and they release them. This isn't okay.
Yeah.
This is not okay. They're having psychosis with these commanding hallucinations, saying they want to die. So they're taking meth, they're taking fentanyl, they're doing alcohol to get those voices out. And sometimes they can't do it. I lost a client because they didn't listen. They didn't get him the help they needed because they just thought he was an unhoused individual that was using meth and alcohol, but they weren't listening. I did. I kept putting him on a hold. I kept trying. We worked so hard. I had committee meetings with the various programs themed. They all said the same. Oh, he's just drinking. He just has substance use issue. He needs to get clean. Address the issue.
Yeah.
That was a hard one when I found out that he passed. The hardest day. I stayed home for like 3 days after that because I had to take care of myself. Because I worked with him for 6 months. I put him on 10 holds. Nothing. So that was before SB 43. That was before.
Yeah.
He didn't make it to SB 43. We lost his life in December. This went into effect in January. So my hope is that SB 43 will bring me that change that we need.
Yeah.
In theory, it will. We'll see. We'll see. Sorry, that one got me. I even had a little tear. Sorry about that. I remember him so well and so
No
vividly.
worries.
Just look at me. Charli, what are you going to do for me today? That's what he would say.
Yeah.
Another major shift is that, of course, the co-responder model. We've talked a lot about that. I believe that shift is really going to help us because, like I said, we're teaching. I work really hard with them, teaching them about mental health. So I think that's going to be a really good shift. Um, and it's funny is the officers are excited about learning about things too, not just about mental health for the I call them clients. I never know what they want to call them, but for my clients going out there, the the perps or whatever they want to call them.
Yeah, right.
You know, um, I think it's kind of the shift there is we also just had a recent um death by suicide from an officer in San Mateo County. I've seen a shift with clinicians inside the PD to start preventing or helping or assisting, having programs there for these officers. We see so much trauma, and I'm going to put myself as a first responder too. We see so much trauma and death, and we listening to it all day long for 10 hours. We're listening to the radio going, is our officer going to come home safe to the station that night? We might not be out there, but we're listening to it. But I've noticed a shift in the PDs. They're having more wellness symposiums. They're having um, therapists. They can, and if you don't want to be seen, they have stuff that nobody knows about that you're going to see, and they pay for it. So that's a really positive shift. We're trying to prevent death by suicide, mostly the blue deaths. We've had 3 in the last 3 years in San Mateo County. That's too many. So that's something I'm very hopeful about. We also have like care court. I haven't gotten totally into that one yet, but it's a good program in theory too. But the client has to be willing to participate, and not all clients are willing. Of course, you have the acute outpatient services, so treatment. Um, I think we're starting to use different language when we are talking to people in crisis. I think we're getting away with, things saying like, what's wrong with you? Instead of saying, like, how can I support you through this? And what's
Yeah.
going to help you stabilize instead of fixing it for them too. It has to be autonomy, you know.
Yeah.
Um, I think the best part though is they're bringing social emotional learning into the schools, and that is allowing youth to speak up about mental health. And that's good. That brings me
Yeah.
a lot of hope.
You find, let's see, how do I ask this question? Well, let me just ask it. Um, have you been able to see more cultures that are like, for example, I asked this completely wrong. Like, do you see more Hispanics as opposed to Blacks? Or is it pretty even across the board?
Well, where I'm at, we have a big Asian community and Hispanic community.
Mhm.
Um, that's our probably our biggest, but I think it's cross culture.
Yeah.
I don't think it's one or the other. I do know both in the Hispanic and the Asian community that mental health isn't talked about. Mental health is seen as something different.
Yeah.
Um, so there's not a lot of reaching out in the Hispanic community. I think they go towards alcohol and substance use more
Sure.
than the Asian community. Asian community just shuts down, don't talk about it, or it's the ancestors, or, there's lots of different layers. But I, I think that just thinking of my JAG reports, it's pretty even across the board in my
Yeah.
communities. There's not one that spikes more than the other.
Interesting. Natalie, I have a question for you. Do you want to do a part two? Or are you all pressed for time, or do you want to just keep going with your, because I know we haven't done your questions at all yet.
Yeah, you know what I was gonna say was, yes, definitely to a part 2, Charlie, if you're up for that. I actually kind of pivoted in my mind because you actually genuinely answered a lot of the questions I already had. So I only had 2 that I wanted to just, see your thoughts on before, we get to the end of the show. So I think yes, definitely yes to a part 2. I think viewers would cherish more of your thoughtful mind. So let me flow into the last 2 questions, and then we'll let my mom, close out the show, if that's okay with you.
Sounds wonderful.
Okay. So my thoughts as I'm hearing all of this good information, 2 things that I want to ask you are, the first one is, I love getting on the back end of things. So I love prevention work. And I think there's just so much that we can do as a human being, as a member of society, within our own workings in the community, however we present ourselves, right? There's always this space of, well, how can we observe the things that are happening and contribute in whatever way that is to helping to make systems better, right? To helping people to figure out better ways to cope with the mind, with stress, with trauma, with not meeting your
Yeah.
basic needs, right? So for you, the question really is, what's your thought process around that? How do you work in prevention now, being there at the PD for 2 years? What has that looked like? Or are you still working on it? Or are there preventative workshops that you do with the officers? Like, what's your thoughts on that space?
That's a really great question. I believe in prevention too. I really do. I believe if we are informed, then we can make better decisions in how to help assist others and how to cope with them. I do trainings with my PD, all from what does psychosis look like versus substance use. Um, I do some grounding um, training with them. I I'm working on a 6-part series right now, being not should say teaching, um, giving them information about suicide ideation in cops, what to look for, how to respond, what's the best programs to get to. And I'm doing it during briefing time. So it's a 15-minute short little part. And their attention span is about that amount. I've noticed. I've done a longer one and they start rolling their eyes. So I really trying to focus on that 15-minute. Let me just do this really quick. If you have questions, we can answer them. And that's what usually gets going is I do these trainings and then we sit there and talk for another hour. If they get, dispatch gets a little
Yeah.
upset, but it's good for them. Um, I also get referrals. Like if there is a person that's in distress, they didn't might meet criteria that night. They didn't go criminally anywhere. They just went out and they're not sure. And this happens a lot on graveyard
Mm.
because I'm
Yeah.
nowhere to be seen. And I get a referral. I call them. I give them resources. I talk to them. I give them my phone number. Some people call me continuously after that. That's okay. I'm all right with that. And that allows them to get where the next step is. Far as my issues with the systemic barriers that I'm hitting and been hitting for the last 2 years, I'm speaking up. I go
Yeah.
into these meetings for SB 43 and say, okay, I want to know what happens after they get. Mhm. I want to know if it's not happening. I tell somebody, usually Shirley from San Mateo County. He looked into it, which is good. I've written letters to a facility saying this is not okay. I've taken other actions where um, I form a group of like all the care providers and talk about that certain client. We get ROIs. We do a clinical um, debriefing or whatever you would like to call it, to kind of have a plan of action on how to help this person. So those are all like preventive things that I
Mhm.
do. Um, I love training, so I love creating. So I do that. That's my little thing. But with my ADHD, sometimes I forget. I do some squirrel. Like I'll be working on it, and then I lose my focus. Um, so I'm learning how to deal with that. But I'm like I said, I'm developing that six part series soon. I also put together a book, which I have not distributed yet, for the schools and mental health and how parents can cope with it, because it's hard for a parent to cope with mental health.
Yes.
How do I get through the systems? Um, I have to do some editing on that, but I had to take care of other stuff, so I kind of put that in the back burner, but I'm working on that as well. So there's a lot of things I'm doing differently.
I love that.
It's
I love all
fantastic.
of that. That is
Yes.
amazing work. I mean,
Yes.
prevention is such a big word and there's so many layers to it. So I love that it just came out of you. Whatever it is that you're doing, and you are doing a lot of things. Um, I would definitely love to chat with you more about that, specifically just being in this role, because that's part of my work and I've only been there for a couple of months. So I'm just a baby starting off. And so that's going to be really helpful information for me going forward. So, lastly, I was thinking about programs and services in our county. And I know that there's a good handful, but I would love for you to just mention a couple that you think are doing a great job or that you want to highlight, or just information for the public, right? Of programs that maybe they can go to. Because I think it's important, like, there's so many layers to positives and negatives and things that have worked and haven't worked. But these programs, they're taxpayer dollars that are going to these programs, right? And so I think it's important to uplift, our community partners, right? And there are a few that I love working with that I think have done some great work and help for me in co-response with members of our community. So, what's your thoughts on that?
I utilize LifeMoves a lot.
That's a good one.
I'm on their I everybody knows me at LifeMoves, because I call them probably at least 2 to 10 times a week,
Yeah.
depending on my caseload. Um, and I've got the inside source now, so if you need that, let me know,
Okay.
to get them rapid response out there so that I'm not standing out there for an hour waiting for them,
Right.
you know, because sometimes that can happen. They're my big ones. And you have to, those are for the unhoused, to get them into shelter. Not everybody wants to go into the shelter system, and we have to respect that.
Mm.
You know, that's something we have to respect. The other one is dialing 988. The 988 programs is tremendous. It's not just when you're suicidal, it's for crisis. If you want to chat for 5 minutes, if you want to chat for 15 minutes, if you feel like you just need to talk to somebody, it's a good start. Now, it's not one that you can call every day and chat every day. We want to make sure that that's not utilized like that. But it's a good start. They can give you resources. They can um, send somebody out if they need to. There's a lot of good things with the 988. It's just not about suicide ideation. And a lot of people think that, oh, I'm just going to dial 988. I know our San Mateo 988 really well because I worked with one of the people that the program manager. She was with me during supervision, and I got to know her really well. Reach out to them. It's a good thing. 988 is national. And so you can call it anytime, but it's just to let everybody know they need to make sure you tell them where you're at so you get the right resources, because they might connect you to the wrong resources because where your phone number is or what your area code is. So that's something that we have to remember. Always tell them where you're at. The other one I would say is the 211 system,
Mhm.
the behavioral health, where you can get intake, where you can um, utilize it for what's it, the SNAP program now. It's your core agency. So it allows you to um, start getting benefits if you need that. So that's a really big one. I said, have you called 211? No. Oh, would you like to do it together? We'll do it together because it's overwhelming. Or have you
Mhm.
gone to your core agency? Find where your core agency is. There's
Mhm.
several in San Mateo County. Um, the other one for behavioral health I use is North County Behavioral Health Services. And I don't know if you've got one of those, I call them my Bible, the community resource guide. It's the best thing in the world. It has everything in there from things for shelter, food, dogs, you name it. It has everything in there. Um, I hand those out regularly. We haven't gotten the 2026 yet, but I'm
Right.
still handing out the 2020.
Right.
Um, but that is a great resource. Great resource. I hand that out. And the other resources is, but there's so many in San Mateo County. I was talking to someone the other day. We have one of the best mental health programs in Northern California, in San Mateo County.
Really?
That is, yep, it's so
Wow.
wonderful. So reach out to Health Right and to, I think, oh my gosh, there's so many.
There's so many.
We have the Serenity House. Yeah.
Yeah, that's a good one.
We have the Serenity House. It's great, for crisis, mental health needs. We also have the Pride Center, which is San Mateo Pride Center now. And they're great. They have a lot of different resources for those that are transitioning, those are, wanting to be heard. We have lots of programs in San Mateo County.
Yeah, we are definitely blessed with that. So, and those are awesome. The ones that you've mentioned, I have worked with, and they're great. And I love having programs where it can be like a one-stop shop, right? Where they can get this individual connected with all of the basic things and then the higher level things, right? It's just super helpful to not have to push them through to so many different places. So, thank you for those. I would love to ask you more, but we are ending the end of the show. So I'm going to pass it over to my mom so she can close us out. But Charli, this is amazing. I'm really excited for a part two.
Yes.
I think we can delve deeper into and dissect the role itself, and just talk more about the facets of it. So stay tuned for that. But thank you.
Thank you.
Charli, I think having you out there, um, I am not even, I'm 3,000 miles away, and seeing you on screen, I feel your warmth. And I I can only hope that the people that you are helping, the people that need you, can feel your warmth, if that makes sense. I might be going a little bit too deep, but I would want to have a Charli if I was in a crisis. I would want to know that the person that I'm going to or divulging information to, I can trust based on their warmth. And I get that from you. So I appreciate the people that you help, because I think it's important that they have a level of comfort. It's not just, okay, how can I help you? Or it's a little bit deeper than empathy. And I think what helps too is you have been through trauma. Um, I've had a level of trauma. So you have that warmth there because of it. It's not taught. It's innate, I believe. So thank you so much for being candid, for sharing. And I look forward to having you on part 2 because I need to know what all these codes are, like 1050 or hold. And so we need to go through all of that, Charli.
Oh, I'm
And
still working on that.
yeah, yeah. I think for our viewers, a hold is this and that, and I think that would help out a little bit, but for me too. So, and for our viewers, those of you who have hung on this long with us on the podcast, please like and subscribe.
Mhm.
Um, this helps us to actually helps my husband with the analytics and how we can grow this and get better. And we're always looking for um, advice or whatever. But this helps my daughter and I move forward and have good content. So, Charli, a warm, warm thank you from me for being on our show today.
I appreciate it. Thank you.
And we will talk soon.